Hematologic problems. Priority concepts in this um, topic are perfusion and immunity. The perfusion concept exemplar is sickle cell disease, and the immunity exemplar is leukemia. The interrelated concepts are cellular regulation, gas exchange, and clotting. Sickle cell disease is a genetic hemoglobin disorder. We have formation of abnormal hemoglobin chains that causes chronic anemia, pain, disability, organ damage, an increased risk for infection, and early death due to poor blood perfusion. These sickled cells become rigid and begin to clump together. They block blood flow and perfusion, and we call this a vaso-occlusive event. This will lead to further tissue hypoxia and the formation of more sickle-shaped cells, and this creates further blood vessel obstruction, inadequate perfusion, and ischemia. Causes of sickling can include hypoxia, dehydration, infection, venous stasis, pregnancy, alcohol consumption, high altitudes, low or high environmental temperatures, acidosis, strenuous exercise, emotional stress, nicotine use, especially cigarettes, and anesthesia. So if you look at what all of these things have in common, it's basically things that will cause vasoconstriction or an increased oxygen demand. These sickled cells can return to the normal shape if the precipitating condition is removed and perfusion is restored, but the cell membranes are damaged over time and they become more fragile and then are more easily broken. The lifespan of these affected RBCs is only 10 to 20 days versus the normal 120 days, and this will lead to hemolytic anemia. There are periodic episodes of cellular sickling, and these are called crises. These episodes come on suddenly. They can be as frequent as weekly and as infrequent as yearly in occurrence. With repeated episodes of these vaso-occlusive episodes and impaired perfusion, we start to see long-term damage to tissue and organs resulting from tissue hypoxia, anoxia, ischemia, and cell death. And then we have the resulting issue of tissue infarction and scar tissue formation. The most commonly affected areas are the spleen, liver, heart, kidneys, brain, joints, bones, and retina. The average client lifespan of someone with sickle cell disease of the male is 42 years, female is 48 years. 1 in 100,000 people have SCD, but 1 in 500 African Americans have the disease, with 1 in 13 African Americans being carriers of the disease. So as we begin to recognize and analyze our cues, of course, we need to do our assessment. We gather our history, so we ask about previous episodes, triggers, the severity, and how those episodes were managed, recent contact with ill people, and review all activities and events of the previous 24 hours to try and determine the triggers. With the physical assessment, we know that pain is the most common sickle cell disease symptom. We see cardiovascular changes that can result in heart failure, shortness of breath, general fatigue, weakness, heart murmurs, an S3 sound, jugular vein distension, tachycardia, and hypotension. Respiratory changes that can result in pulmonary hypertension, recurrent pneumonia, and acute chest syndrome, which is a common reason for hospitalization and is the most common cause of death. It's usually associated with respiratory infection, fat embolism, or debris from sickled cells. The symptoms of the acute chest syndrome are very similar to pneumonia and include a cough, shortness of breath, abnormal breath sounds, and infiltrates on the chest x-ray, possibly fever, and it can lead to respiratory failure and multiple organ failure syndrome. Something else we may see is priapism, which is a prolonged penile erection, and there is severe pain with this, in addition to an inability to urinate. Skin changes would include pallor or cyanosis, especially in the lips and tongue, which the color will be more gray, and the palms, soles, conjunctiva, and nail beds, where we'll see the blue tinge. And this is all due to poor gas exchange, decreased perfusion and anemia, jaundice from red blood cell destruction, and it may cause intense itching. We may see ulcers on the lower legs due to that poor perfusion, and those ulcers can become necrotic or infected. And we also need to watch for discoloration of the feet and toes and fingers. Abdominal changes include damage to the spleen and liver from repetitive hypoxia and ischemia episodes, and those organs can be large and nodular. There can be diffuse and steady abdominal pain that radiates into the back and the legs. We may see chronic kidney disease. We can also see joint damage from hypoxia and necrotic degeneration, along with swelling of the joints, temperature changes, movement restriction, and pain. With the central nervous system, we may see that low-grade fever with a crisis, seizures or stroke due to infarcts from hypoxia, a pronator drift, abnormal gait, coordination, and strength. Psychosocially, we may see cognitive and behavioral changes from cerebral hypoxia. Diagnosis will be based on the percentage of abnormal hemoglobin and the number of permanently sickled red blood cells. The hematocrit will be low, the reticulocyte count will be high, and total bilirubin level may also be high. The white blood cell count is usually high due to chronic inflammation. We can also do imaging, and this may show bone changes due to chronically stimulated bone marrow and low bone oxygen levels. The skull may have a crew cut appearance. The joints may show necrosis and destruction. MRIs may show soft tissue and organ changes from poor perfusion and chronic inflammation. If we do an ECG, this may indicate cardiac infarcts and tissue damage, while an echocardiogram may show cardiomyopathy and decreased cardiac output. The priority collaborative problems for the client with sickle cell disease include pain related to poor tissue oxygenation and joint destruction. Remember, the pain in these clients is going to come from ischemia. When the tissues are not getting oxygen, it hurts. The other priority collaborative problem is potential for infection, sepsis, multiple organ dysfunction, and death. So how do we treat this? Well, first of all, we need to manage the pain. Again, the pain is coming from the tissue injury caused by poor perfusion and tissue gas exchange, ischemia. We can use distraction and relaxation techniques, positioning, aromatherapy, warm soaks, therapeutic touch. These will alter the pain perception. We can also give drug therapy. We will usually start with IV opioid administration for about 48 hours and then switch to oral once the pain is better controlled. Moderate pain may be able to be managed with NSAIDs. We can also give hydroxyurea, which will stimulate fetal hemoglobin production and can decrease sickling and pain episodes in some SCD clients. However, this drug does increase the risk for leukemia and can suppress bone marrow function. Another drug is Indari, which can decrease sickling and increase RBC life. And then we have another one, Crizanlizumab, can also prevent cell adhesiveness, which will reduce those vaso-occlusive crises. We need to administer oxygen, give IV and oral hydration, no caffeine. We will be using hypotonic fluids at 250 mLs per hour for 4 hours and then decrease it to 125 mLs per hour as necessary for hydration. Remove anything that could constrict blood flow, such as constrictive clothing. Encourage the client to keep their limbs straightened to help promote the flow of blood and prevent venous stasis. Don't raise the knee gatch on the bed. Keep the room temperature at least 72 degrees. Avoid blood pressure with the standard or automatic external arm cuff. Check extremity circulation hourly through pulse oximetry, peripheral pulse palpation, and capillary refill. Prevent sepsis through continual assessment, prevention and early detection of potential infection, and potentially prophylactic antibiotics. These clients may also require blood transfusions, hematopoietic stem cell transplants, and client education on prevention, which will include 3 to 4 liters of fluid a day, avoiding alcohol and nicotine, obtaining the annual flu shot, avoiding extremes of hot and cold temperatures, wearing socks and gloves on cold days. Avoid airplane rides in an unpressurized passenger cabin. Avoid travel to high altitudes and avoid strenuous exercise. Anemia is a reduction in either the number of red blood cells, the amount of hemoglobin, or the amount of hematocrit. It is not a specific disease. However, it is considered a clinical indicator with the manifestation of several abnormal conditions. Common causes of anemia include dietary problems, genetic disorders, bone marrow disease, or excessive bleeding, with GI bleed being a common reason for adult anemia. And it can be from a decreased red blood cell production, an increased red blood cell destruction, or chronic red blood cell loss. Types of anemia include sickle cell disease, which we just talked about, the glucose 6-phosphate dehydrogenase deficiency anemia, which is a genetic cause, autoimmune hemolytic anemia, where we have self-destruction of those red blood cells, iron deficiency anemia, which occurs from inadequate intake malabsorption or increased metabolic use of iron, pernicious anemia, which occurs from inadequate vitamin B12 intake or an inability to absorb vitamin B12, folic acid deficiency anemia from an inadequate intake or malabsorption of folic acid, and aplastic anemia from exposure to myelotoxic agents or potentially a viral infection. We're talking like chemotherapy, for example, or radiation therapy. So as we're looking at anemia, we need to know the signs and symptoms. Generally, there's going to be some pallor, especially around the ears, the nail beds, the palm creases, and around the mouth. The skin will be cool to touch. The client has an intolerance to cold temperatures. With chronic issues, the nail beds will then become brittle and concave. With the cardiovascular, we have continuous tachycardia that increases after meals and with activity. We may also auscultate murmurs and gallops, and the client may have orthostatic hypotension. With respiratory, the client is breathless with exertion. And think about it for a minute. Red blood cells are going to be carrying oxygen to the tissues, and if we have a decreased number, we're not getting oxygen to the tissues. We also have decreased oxygen saturation levels. Neurologically, the client may be fatigued, require increased sleep, and have reduced energy levels. So what are we going to do? Well, monitor vital signs, the cardiac, respiratory, and neurological symptoms. Encourage the client to change position slowly. Consider this client to be a fall risk and take appropriate action. Increase the fluid intake, including intravenous fluids. Encourage foods that are high in iron and/or iron supplements, foods that are high in vitamin B12 and/or supplements or injections, and foods that are high in folic acid and/or supplements. Immunosuppressive therapy. Make sure that you monitor the stools and vomitus for blood and keep an eye on those lab values. And then we may need to transfuse blood products or plasma expanders. Different types of transfusions that we may give would be the red blood cell transfusions to replace cells lost from trauma or surgery, hemorrhage. Platelet transfusions given for low platelet cell counts, also known as thrombocytopenia or active bleeding. Plasma transfusions to replace blood volume and clotting factors. And granulocyte transfusions for clients who are neutropenic and are not responding to antibiotic therapy or sepsis. Now we know that there are basically 4 different types of blood, and a type and cross match has to be done prior to transfusion to determine the client's blood type to prevent lethal reactions. If a client has the A antigen, they're type A. If they have the B antigen, they're type B. If they have both A and B antigens, they're type AB. But if they have neither the A or B antigen, they're type O. And then we have the Rh antigen system, which provides the positive or negative aspect of the blood type. If a client is Rh negative, there is no Rh antigen on the RBCs, and the client does not form antibodies unless specifically sensitized to it. That sensitization will occur from transfusions or exposure during pregnancy. And once that sensitization occurs, antibodies will begin to form, and re-exposure can cause that transfusion reaction. Antibody development can be prevented by the administration of an anti-Rh immunoglobulin, such as RhoGAM, and we often see this given to our obstetric clients who are Rh negative to prevent antibodies forming if the fetus is Rh positive. If the fetus is Rh positive and mom does not receive RhoGAM, she can abort this baby unintentionally because of that incompatibility. The body is getting rid of the non-self cells. An Rh positive client can receive Rh negative blood, but the Rh negative client has to receive Rh negative blood. So how do we transfuse? Well, before the transfusion, we have to verify that prescription. Make sure that we are doing what we need to do. Then we are going to test the donor and the recipient for compatibility. We're going to do a type and cross match of the blood. So we're determining the client's blood type, and then we're cross matching it with the donor. We need to prepare a straight or wide tubing with a blood filter, and then when we infuse the blood, we will use only normal saline. Never use anything else because it can cause clotting or hemolysis of the blood. We can only transfuse 1 unit at a time except in emergent situations, and never infuse medications in the same port as blood products. Once we retrieve that blood from the blood bank, the blood has to be initiated within 30 minutes. So once we get the blood retrieved from the blood bank, we have to examine the blood bag label, the attached tag, and the requisition slip. We're looking at ABO and Rh compatibility to the client with another RN. We're also checking that expiration date and inspecting the blood for discoloration, gas bubbles, and cloudiness. Again, all of this is done with another registered nurse. During transfusion, we need to provide client education. The client needs to know what we're doing and why we're doing this. We need to assess their vital signs immediately before starting the infusion. Now, other personnel can obtain this. A UAP can obtain those vital signs, but it is the responsibility of the registered nurse to transcribe those vital signs and be aware of what they are, making sure that they have been obtained. We begin the transfusion slowly. We will stay with the client for the first 15 to 30 minutes per facility protocol because the severe reactions will usually occur with the infusion of the first 50 mLs of the blood product. We ask the client to report any unusual sensations, for example, chills, shortness of breath, hives, itching, pain, etc. We administer the blood product per protocol, looking at how frequently do we obtain the vital signs and how fast do we infuse the product per the facility policy, realizing that the older adult may require a slower infusion rate to avoid fluid volume overload. And there is also a possibility for electrolyte imbalance, especially hyperkalemia. So we do need to monitor the client for potential electrolyte imbalances. We also need to monitor the client for acute transfusion reactions. Now, we're not going to discuss all of the reactions, but we are going to discuss the more common ones. Febrile. This is probably the most common transfusion reaction, and it occurs most often in the client with anti-white blood cell antibodies. So in other words, we're reacting to the donor's leukocytes. These clients will experience chills, fever, tachycardia, hypotension, and/or tachypnea. A hemolytic reaction is caused by a blood type or Rh incompatibility. These clients experience fever, chills. They can experience life-threatening issues such as DIC. Other symptoms can include chest pain, back pain, apprehension, tachycardia, tachypnea, hypotension, and headache. Allergic reactions are often seen in clients that have other allergies, and they can experience urticaria, hives, itching, bronchospasm, or anaphylaxis. Bacterial infections come from contaminated blood products. These clients have a rapid onset of tachycardia, hypotension, fever, chills, and/or shock. Circulatory overload results from a rapid transfusion, again, especially in the older adults. They may have the fluid volume overload symptoms such as hypertension, bounding pulse, distended jugular veins, dyspnea, restlessness, confusion. Now, a not so common reaction would be transfusion-associated graft versus host disease. It's rare, but it is life-threatening, and it will occur most often in the immunocompromised client, usually within 1 to 2 weeks after transfusion. These clients will have thrombocytopenia, anorexia, nausea, vomiting, chronic hepatitis, weight loss, and recurrent infection. Now, what do we do if the client experiences a reaction? Well, first of all, we stop the transfusion. We are going to disconnect the blood product and the normal saline, infuse normal saline using a brand new tubing. It can go in the same site because it's not the site that's bad. It's not necessarily the blood that's bad. The client is just reacting to that particular unit. So stop it, remove it, infuse normal saline using different tubing. We're going to obtain vital signs, so we're going to get a quick reassessment of our client as we always would with a change in client status. We need to prepare to potentially receive or obtain blood samples from the client, a urine sample, and treat the client symptomatically. We will send the entire blood component bag with the tubing and the normal saline that we were using to transfuse back to the blood bank. Now, there are occasions where sometimes we will just have a mild reaction where we'll have a slight elevation in the temperature, or the client may have a little bit of a rash or itching, but it's not severe. Please do not misunderstand. This does require a physician's order. Sometimes we can do one of two things. We can slow down the infusion rate and/or administer an antihistamine such as diphenhydramine and potentially uh, acetaminophen. Again, mild reactions will require that we contact the healthcare provider, which we should do anyway, to determine if they want this unit to continue or not. Some providers will pre-medicate their clients prior to transfusion, which will require the administration of an antihistamine such as diphenhydramine and or acetaminophen, and that does eliminate some of those mild reactions. So again, follow your policy protocol. Reactions, you have to stop it, discontinue it, unless it is a mild reaction and your provider has ordered you to make those changes. So we have a 27-year-old female with a history of sickle cell disease who comes to the emergency department with abdominal pain that is rated as a 9 on a 0 to 10 scale. Physical assessment shows that she's grimacing and guarding her abdomen and has a fever of 103, a pale yellow hard palate, and several very small ulcers on her lower extremities. What is the priority problem that the nurse must immediately address? The acute pain, the hyperthermia, the potential for infection, the decreased tissue perfusion. The priority issue is A, the acute pain. We have to control that first and foremost, and then address the other issues. 30 minutes later, the client is diagnosed with acute sickle cell crises. She continues to have pain. Which drugs does the nurse anticipate would be prescribed for pain control at this time? Select all that apply. Meperidine IV push PRN, acetaminophen orally or rectally, hydromorphone IV push scheduled doses, morphine sulfate IV push scheduled doses, morphine sulfate slow release oral or IM scheduled doses. The correct answers are C and D. A client in sickle cell crises often starts with at least 48 hours of that IV analgesia. Morphine and hydromorphone are given IV on a regular schedule or using the PCA pump. Once relief is established, then the IV dose can be tapered and we can start giving the oral medications. PRN dosages should be avoided because they do not provide adequate pain relief, and IM injections should be avoided because that absorption is impaired. The client has poor perfusion and maybe some sclerosed skin. 3 hours later, the client is admitted to the acute medical care unit and lab studies are ordered. Which result does the nurse anticipate? Hematocrit 40%, HbS 90%, WBCs 7,000, total bilirubin 0.5. The correct answer is B. The HbS is going to be showing the sickle cell hemoglobin. Clients with SCD usually have a low hematocrit, high white blood cell, and high total bilirubin. The provider's orders include hydroxyurea. 2 hours later, when the nurse administers the medication, the client asks about the purpose of this drug. What is the appropriate nursing response? Well, hydroxyurea can be used to reduce the number of sickling and pain episodes. So what follow-up lab values would the nurse monitor while the client is taking hydroxyurea? a CBC, because it will suppress the bone marrow function. So we have to monitor those blood counts. 4 days later, the client is preparing to discharge. Which teaching points should the nurse provide to the client and her family? Select all that apply. Be sure to get a flu shot annually. Drink at least 3 to 4 liters of fluid daily. Avoid temperature extremes of hot or cold. Alcoholic beverages may be consumed moderately. Engage in mild, low-impact exercises 3 times a week when not in crises. The correct answers are going to be A, B, C, and E. The only incorrect one is D. We know that hydration is very important. Flu shots are important because we want to decrease that risk of infection. And low impact exercises should also be engaged in. We do not want strenuous exercise. Clients should always avoid alcoholic beverages, and they should always avoid those temperature extremes of hot or cold. So the only incorrect answer is D. A 23-year-old African American male with a history of sickle cell disease had an emergent open reduction and internal fixation of his right femur after a car crash. What is the initial postoperative nursing priority? Treating the client's pain, ensuring adequate IV hydration, titrating oxygen to an SpO2 greater than 95, examining the surgical incision for signs and symptoms of infection. The correct answer is B. We have to maintain that hydration. He's not having any issues with the sickle cell disease, but he can. So we need to, we know that anesthesia and stress and the trauma of the car crash can all precipitate a sickle cell crisis. Adequate hydration is a priority to help support vital signs as well as treat that sickle cell symptom and sickle cell associated pain. Effective hydration is going to also augment pain management strategies that we use to help treat sickle cell disease. Oxygenation is also important, but at this point, once again, the client is not experiencing a sickle cell issue. So we need to prevent the formation of those issues with hydration. What is the priority nursing intervention in the care of an older adult with a history of diverticular disease and pernicious anemia? Preventing falls, monitoring intake and output, turning the client every 2 hours, encouraging a diet high in vitamin B12. The correct answer is A. The client's going to have difficulty absorbing vitamin B12 because of the diverticular disease and may have developed paresthesia in the feet, which increases the risk for falls. And anemia can also increase the client's symptom of weakness, thereby increasing that fall risk. So preventing falls is a priority intervention. When we're determining priority, remember ABCs first. Then we look at mental status changes and safety issues as being fourth and fifth, either order. So preventing falls. Last question. A client with polycythemia vera is admitted with reports of shortness of breath, hypertension, and loss of pulses in her right foot. Which is the priority nursing intervention? Assessing current hydration status, administering oxygen by nasal cannula, Evaluate her elevate her lower extremities on pillows. Evaluate the client for hypertensive crises. The correct answer is A. Polycythemia vera is a form of malignant RBC hyperproduction and clotting factor dysfunction, and it requires evaluation of intravascular hydration, preparation of lab tests for possible therapeutic phlebotomy, and anticoagulant therapy to decrease clot formation. Clients with this disease are going to be at risk for hypertension, and they will experience poor tissue oxygenation as well, requiring assessment. Raising the lower extremities may assist with perfusion and symptoms, but would not be a priority in this scenario. Correct answer, once again, A.